All right. Well, good almost afternoon for those in the East Coast, and good morning to those in my neck of the woods here in Arizona. I just wanted to start out by saying thank you for taking the time out of your very busy schedules to watch this lecture and just allowing me to be part of this project. I'm very flattered that and really fortunate that Drs. Gentili and Cowan really had that confidence in me to allow me to participate with this. And I really want to share my appreciation for the Ohio Department of Mental Health and Addiction Services and the Ohio Department of Developmental Disabilities for being able to identify those opportunities for us to enhance all of our abilities to care for those with intellectual disabilities and then making this all possible. So thank you to all of those. I will start going now, and we will make this work. Okay, there we go. All right, so this is actually part one of a two-part lecture on pharmacological management for individuals with intellectual disabilities, and I am Dr. David William Dixon. So it's nice to meet you. I do not have any financial disclosures. I don't make any money, as far as I'm aware, off of any particular pharmaceutical companies. So there you go. Just a quick little thing about who I am. So I am a ABPN board certified psychiatrist, American Board of Psychiatry and Neurology. I got my bachelor's degree at Arizona State University. I went to medical school in Arizona at A.T. Still University School of Osteopathic Medicine in Arizona. And then I was fortunate enough to be selected into what I think is probably one of the best residency programs for psychiatry, the Wright State University Boonshoff School of Medicine residency program in Dayton, Ohio. Lovely time, really just enjoyed it so much. After I got through my residency, where I was the chief resident, actually, I was on active duty military, and I ended up being the medical director for the inpatient psychiatric unit at Brooke Army Medical Center, and working with the residents down there. Also a great program, so I won't diss on them. And I also worked extensively with the Uniformed Services University's psychiatric clerkship as the site director there at Brooke Army Medical Center. I was actually really fortunate during COVID when that started happening, that we were working in inpatient psychiatric unit, and we needed to convert over to telehealth. And actually, it was my experience working with patients with intellectual disabilities who actually afforded me the most of my experience with that. So I was able to do a lot of telehealth during residency working with this group, and I really absolutely loved it. And so I was really an advantage. Currently, I'm actually in the Air Force Reserves. I'm out of Fort Worth, Texas. I live in Arizona, so that's a fun move sometimes. And I work for a private company, a Second Chance Treatment Center, doing almost entirely telepsychiatry in Gilbert, Arizona. So I do some assistant professor things as well with students and residents. Now, one of the things I really wanted to know is, who are you? I wish I could get everyone to stand up and tell me who they are, but 162 people seems like a lot. So hopefully we're seeing everybody who's involved with anybody who's ID, intellectual disabilities, including possibly individuals who have ID themselves. So talking about the caregivers, we're talking about the providers, and even possibly legal professionals. So really, hopefully we have a pretty good mishmash of various people here to kind of learn about this topic. So I did try to keep this topic hopefully palatable to most people, and we'll move on. So the objectives for these two topics, part one is going to focus, this is what we're really going to focus on today, which is just being able to recognize these common medication classes. What I want you to be able to do is just gain some of the familiarity with the commonly used psychotropic medications, and we'll highlight maybe some things that are you're going to see more with ID. But to be quite honest, with the various age ranges that you'll see, you're going to see a lot of different medications. One thing that I want to point out is that I will use generic names. Okay, I'm going to try really hard not to use brand names. So I apologize, but if you don't know the generic names, but I'll try to go over some maybe the common class side effects, maybe some potentially some common doses if we have time. And just to be everyone's aware, this is a really enormous topic. Volumes and volumes already written on this, at least the medications themselves, and just being familiar with it. So I don't really want everyone to be an expert after this lecture, but I do want you to have some just some familiarities, just to be able to recognize, okay, oh, that medication maybe comes to this class, or at the very least, when somebody says SSRI, I want you to have an idea, a vague idea of what that means and maybe what it's going to be treating. And then for part two, we're going to be looking at these things, but that's going to be for the next lecture. That's going to be probably a little bit more targeted towards the actual providers, the people who are going to be prescribing medications, but can be useful for anybody. So now, if you have any questions, there is a questions part right here, which I have opened up. I can see it now. Somebody will shout out to me if I miss anything. I will feel free to ask if you have questions. Don't hesitate. I'm happy to ask. I'm happy to answer something if it's going to be answered relatively quickly with a slide. Then I might hold off. But if it's something I can answer right away, I will absolutely do that. If it's something that might be more appropriate for a Q&A, we have some time at the end of the lecture to do that. And if it's something that I have no clue on answering, then I may be very honest and I might dance around that, but I'll do my best to give you a very honest and open answer to any questions. So we're going to go through some of the basic information that can be helpful for just understanding this particular topic, psychopharmacological management, which is, again, sounds pretty scary. What is psychopharmacology? And just to break it down, make it really easy, the word psyche or psych, we'll actually maybe highlight this and play with my pen a little bit. I'm going to try to make this interesting with my pen. So if we think about psych, it comes from the word psych, or the means the human soul, mind, or spirit. We're usually actually focused more on this part of it, but that is what it means. It's not going to let me. There we go. Pharmacology is simply the study of how drugs are going to affect the body and just how the body responds to it. Okay, so when we put these two things together, what we're really thinking about is this is just the science of the medications that that function within our minds. Okay, so too long didn't read. And one of the things that I think goes really that can be really difficult for anybody is to understand what some of these things mean on our pill bottles. Okay, so the sig, which is actually Latin for signature, and it means let it be labeled. So the fancy doctor thing that we use to basically say this is how we want you to take your medications. Okay, I'm going to give you some examples. So aripiprazole 5 milligrams, tab, PO, QHS for agitation. This is actually a really good sig, and I'll point out the different parts of it to hopefully show you why, and I'll explain what some of these are. So aripiprazole is the name of our medicine. That's the generic name. We should have a name for the medication. Usually that's good. We can use brand or generic. For all medications have at least 3 names. So there's the generic name, aripiprazole, there's a brand name, which I won't say, and then there's a molecular name, which I could not possibly say. But so you're aware, all medications have those two. So oftentimes when we're speaking with people as prescribers, we might interchange both of those. So apologize. We try in med school to teach our med students to just really know the generic names, because as medications become generic, sometimes the brands don't exist anymore, and then we're just calling something that doesn't really exist. The next part is the actual dose. Okay, so we have the dose of the medication. Typically, this is the amount that we're going to be giving, and milligrams, micrograms, it can be all over the place, but typically you'll see milligrams. Ideally, when they're writing this out, it should be very clear. So 5. If it's 0.1, ideally there should be a 0 in front of it. So 0.1s to just not have any confusion. Typically, the pharmacists are going to be pretty good about making sure that we're doing what we're supposed to, but just so you're aware. The next part, the tab, is the formulation of the medication, or just how it's going to what we're actually giving. You won't always see this, to be honest, in some SIGs, but it's usually good to have an idea, because there might be caplets. It might be a solution. It might be a film. So there are many different ways that we can have the medication. So this just helps us understand, okay, what am I looking at? Is this what I'm supposed to get? And particularly for caregivers, if you're seeing that it's supposed to be tabs, and it's really caps, then there could be an error there. Just make sure that we're bringing that up to at least the prescriber or the pharmacist. Make sure we're getting what we need to. And it can be important because tabs can be split in some cases, not all. Caps typically not. And so there's some important parts of that, and the various ways that it's going to be bioavailable. So is it going to be absorbed properly, things like that. Next, PO. That's the route of administration. So it doesn't have to be PO. It can be all sorts of things. It can be SL, sublingual, which means you let it dissolve under the tongue. PO stands for per Oz, which means by mouth. There's a reason we did that. It makes it hard, I suppose. There's SQ, which is subcutaneous. There's IM, IV, IV, transdermal, a bunch of different ones, but that's just basically telling you, okay, how are we going to be giving this medication? This one always confuses people, and I like this. You can look these up, by the way, the abbreviations, but QHS is just the frequency. So how often are we going to be giving it? The letter Q will typically designate every. Okay, every. So you'll see that in a lot of different ways. You might see QHS, QAM, Q daily. We got away from doing QD. The word daily should be used if we're going to be giving it every day. QHS the HS means before bedtime. You can also see, you'll see these. You probably know these ones: BID, TID, twice daily, 3 times a day. QID is 4 times a day. And then some weird ones, QOD, every other day. That means other. QOW. And then this one's actually probably the most important part of this, I think, as far as for caregivers and even to prescribers. The last part is the indication. Okay, so why are we giving this medication? So important. All right. If this isn't on your SIG, at the very least, we should know why. You should be asking your prescriber, why am I getting this medication? Why is my son? Why is my dad? Why is somebody getting this medication? We should be able to say that. Your prescriber should be able to tell you the answer. This is why we're giving this medication, okay? So I'm going to erase this stuff, and we're going to just give a couple more examples real quick. Fluoxetine, 20 milligrams, so medication. We got our medication, we got our dose, we got our formulation, we got our route, we have our frequency, and we have our indication. And then last, trazodone, 50 milligrams tab, PO by mouth at bedtime or before bedtime, and PRN. So you'll see this one too. PRN means as needed, and then it should basically be for sleep or as needed for something. PRNs are not typically used a lot with ID, but just to be aware, that's what that means. So when they're saying don't do that, if you see that, say no, we need to have a pretty clear indication and timing. Alrighty, so the medication classes. This is a big thing. These are the classes that we will be discussing today, and then some of the subclasses. So the antidepressants, antipsychotics. There's a lot. Okay, this is not exhaustive, but if it seems like we have a lot to go through, the answer is because it is a lot to go through. So we're gonna have to get started, and we'll go through each individual one, and I will try my best to make this as exciting as humanly possible. So let me go back to my previous slide. Now we're good. Antidepressants, got a sad kitty. So these particular medications, the SSRI, so we're going to go over SSRI, selective serotonin reuptake inhibitors. So these work by increasing the amounts of serotonin that's available in the brain, and typically by blocking the serotonin transporter, we call it SERT, that would otherwise bring serotonin when released into the brain around the neurons. It blocks them from coming back up, which opens up, which makes more serotonin in that area. And then there are some downstream effects. So the medications will actually make changes within the brain. Okay, that's important to realize because the amount of time that it takes for the brain to respond to the increase in serotonin has a lot to do with the amount of time that it can take for full effects to actually be seen within the brain. And that's very important. Taking SSRI is probably not going to have a major positive benefit in the first day, maybe not even having the first week or two, sometimes 3. It can take 4 to 6 weeks to see maximum benefit. I would say you usually should see some change within after about 2 weeks. That's important because a lot of the side effects that we'll see are going to have to do with that process. And really this applies to most of these medications. So a couple of examples to give you. So these are the ones, and this is the thing. Hopefully you've had a chance to take some notes on this because I'm going to tell you things. So a couple of examples, and it's probably the big ones you'll most likely see will be fluoxetine. And I apologize for my terrible doctor handwriting. I'm writing on a sertraline, and there's several others. Every once in a while you'll see fluvoxamine. Okay, it's kind of an odd one, but you'll see it. Oops, I went the wrong direction. Go back. Fluvoxamine and maybe citalopram or escitalopram. I'm not going to write them, but those are the names. So, or paroxetine even. So, what are the indications? And that's the important thing. Like, why are we giving this medication? Why would we give this at all? Why is this something that somebody that I love and care about would be taking? For the most part, most of these SSRIs are going to be given for major depressive disorder. And what we think about is the depression itself. Okay. Generalized anxiety disorder, or even just anxiety, bulimia nervosa, sometimes panic disorders, obsessive compulsive disorder, or even PTSD. And they may be especially useful or helpful whenever we're having behavioral issues that are related to anxiety or depression. And so it isn't necessarily going to improve the behavior, and that's not what we're trying to do. I'm not trying to I'm not trying to make somebody stop doing something by just punishing them for it. What I want to do is treat the underlying issue that might be causing that symptom. Okay, so that might be causing that behavior. So treating that particular symptom can be incredibly beneficial. Some of the side effects, and these are going to overlap a lot. So just so you're aware, generally selective serotonin reuptake inhibitors are really well tolerated. There can be a lot of GI effects, and with the ID population, that can be for neurotypical patients. It's a couple of days. You have an upset stomach, maybe you're have some diarrhea or constipation. You just don't feel like eating much. It's something that will go away. For somebody who really can't communicate that they're having that issue, that can be a lot more significant. And that's going to play a big role in how we prescribe these, which we'll talk about in part 2, but just be aware of that. All antidepressants have a class black box warning. Okay, so when the FDA comes and looks at these things, they're going to say, hey, this is something that can happen with these medications, and want to be aware. So I'll try to point out some of the black box warnings on these, particularly with antidepressants. It's that there can be an increase in suicidal ideation in those under the age of 25. And we always have to be aware of what's something called serotonin syndrome, especially when combined with some of these other medications. The ones that are going to be probably the most that we have to watch out for the most are MAOIs and TCAs as far as combinations. So there's a reason we don't want to give a bunch of these medications. Serotonin syndrome is particularly concerning. Lots of confusion. You might have hypertension. You might get febrile or have a fever. And just make sure that you're not using SSRIs, especially fluoxetine, with MAOIs, thyroidazine, pimozide, or tamoxifen. Now, the next one we're looking at is the serotonin norepinephrine reuptake inhibitors, SNRIs. These function very similarly to the serotonin or the SSRIs. The real difference is this word norepinephrine in there, right? Essentially, it's going to function on serotonin quite a bit, but it's also going to have some effect on norepinephrine, which will have some downstream effects on dopamine. Okay, this isn't we're not doing a neuropsych lecture, so I'm not going to get into what all those actually mean, but we'll, at the very least, you're aware now that norepinephrine and serotonin are going to be modified by the serotonin and norepinephrine reuptake inhibitors, but it's basically going to have higher levels of norepinephrine and then eventually dopamine to some extent. So a couple of examples, and many of you probably heard of these too. So these are pretty common medications. There's duloxetine, and the two big ones, I believe, and venlafaxine. There's a new one on the market, or not newer, but another version, desvenlafaxine. This is very similar to venlafaxine. I believe it's a lot more expensive at this point. It doesn't get used a whole lot, but and these have various formulations. There's one called milnacipran that's typically only used for fibromyalgia, so you may not see that one very often. And then levomilnacipran, I really haven't seen either of those prescribed too much, especially in this population. But hey, stranger things have happened. Again, for the indications, typically for these, same thing: depression, major depressive disorder, generalized anxiety disorder, sometimes social anxiety. Fibromyalgia is kind of the big one. You will see the indications here for fibromyalgia, panic disorder, PTSD. Some of these are really good for chronic musculoskeletal pain or even neuropathies, particularly diabetic neuropathies. And these may be especially helpful as well for some of those behavioral issues if you're having a lot of anxiety and depression. I'll get into more of the tips and tricks I got to move on. Again, these are pretty generally well tolerated. A lot of the same typical side effects that you'll see with SSRIs, but you'll actually see potentially a lot of increases in blood pressure. Tends to have the same black box warnings as well. So avoid use with MAOIs and TCAs. And be mindful that all these, anything that's very serotonergic can also, there can be some very rare bleeding and maybe some bruising, emotional flattening, sometimes apathy, or somebody doesn't want to do anything, or even cognitive slowing. All right, next, atypicals. This is a really odd class. This is a difficult class to even talk about because it really has a bunch of different medications and a bunch of different classes. So just putting them together like this is probably unfair because they all have their own. There's some that exist in the same kind of subclasses, but just putting them all together, it's just kind of an understanding. And I think it helps us to realize that maybe we're going to go first here, and then maybe second here, and then maybe start looking at some of these. But there are a lot of reasons that's definitely not a rule, but there might be reasons that we might look in that direction. All these have just, for the most part, there can be various effects on serotonin, can be various effects on norepinephrine, noradrenaline, and even dopamine receptors to some extent. So a couple of examples, bupropion. I'm sure that one's pretty commonly seen, bupropion, because it has a lot of different uses. There's mirtazapine, which this one's a lot more stimulating. This one is very sedating and given at bedtime. There's and this one's kind of weird because it comes in mirtazapine is its own little odd med. It's a noradrenergic and specific serotonergic antidepressant, or NASA. This one appears in NDRI, norepinephrine and dopamine reuptake inhibitor. There's trazodone, which everyone has probably seen this one. It is not typically used for depression. It's usually used for sleep, and so we'll probably see this one a little bit later too. And then there's vilazodone or vortioxetine, and likely many more in the pipeline. Some of the indications, again, varies widely with this because they're so different. You can see nausea being treated with mirtazapine or even appetite stimulation. You can treat some with ADHD, typically off-label. You might see it for PTSD, major depressive disorder, obsessive compulsive disorder, generalized anxiety disorder. So a lot of different reasons for these. And I think in particular, if you're seeing something that's in that class, or at least in that kind of a big larger category, um, ask what the indicate. Why are we giving this medication? Definitely, okay. Um, Try not to assume, because it might be used for a different reason than we think, and we want to make sure that we're using it appropriately. At the very least, we have a clear idea of why we're using that. And then again, the side effects are going to vary widely. Sometimes side effects are used as we can use them as just the effect, like mirtazapine is a very strong sedation quality to it, and so we use it for sleep. Same thing with trazodone. But you can see potential for seizures, hypertension, activation, and then same black box warnings. I put these together for a reason, MAOIs and TCAs, and mainly because you're not going to see these too much, I hope. You're not going to see them a whole lot. There are some very specific uses for some of these that can be really helpful, but they're definitely less commonly seen, mainly because SSRIs, SNRIs, and the atypicals have become much more affordable, tend to have a lot fewer side effects. There tends to be a lot more weight gain, a lot more sedation with MAOIs. Though MAOIs can be very useful for melancholic or atypical depression, so somebody who is just really down in the dumps. But with MAOIs, you have to be on a tyramine restricted diet, okay, for almost all of them. And so diet restriction, that can be really difficult. And especially with that population, if there are their favorite foods they can't have, that can actually lead to some behavioral things. So I'm doing a terrible job of writing restriction because my pen ain't working well. But just some common things. So anything has like strong tyramine in it. So strong aged cheeses, cured meats, smoked or processed meats, pickled or fermented meats, or fermented foods, sauces that might be like soy sauce, shrimp sauce, fish sauce, miso, teriyaki. I would die if I couldn't have miso. Soybeans, snow peas, broad beans like fava beans. Dried or overripe fruits, meat tenderizers, yeast extract spreads. So you're not going to be able to have your Vegemite. That's really rough. Alcoholic beverages like beer, especially homebrewed beer. And then any foods that might have anything else above, and then possibly even improperly stored or spoiled food. So it's really important to just be really cautious about diet with MAOIs. And we will move on. So a couple of examples will be isocarboxazid, which it was made in 1959, so it's been around for a little bit. Carboxazid, primarily used for major depressive disorder. Phenelzine is what I think is probably the most antipsychotic sounding non-antipsychotic medication. For those of you who may or may not be psychiatry residents, you can almost be assured that you'll see a question about phenelzine. And it won't necessarily be about phenelzine. It'll just say, which of these medications would you use? And all the rest will be antipsychotics. And you'll be like, they're all antipsychotics. Well, no, phenelzine's a MAOI. So there you go. Hopefully that helps you. Selegiline is quite a bit newer, came out in 2006. Doesn't necessarily require the tyramine restriction, so that can be helpful. It actually comes in a transdermal patch, and it's for major depressive disorder. And there's several more. I don't want to bore you with that. TCAs, I think we do see every once in a while. A lot of times you'll see them used by neurologists. Sometimes they have pretty good. They have a lot of qualities for neurological conditions, migraine prophylaxis. They can be used potentially for some neuro pain. It can be used for sleep. For some, they're very sedating. And we'll talk about that a little bit later. The big one that you may see nowadays for this population might be clomipramine. It came out in 1984, so it is, what, 38 years old, and it's for OCD. So you'll see that. And then maybe amitriptyline, maybe nortriptyline, maybe imipramine, but that's about it. All right. Antipsychotics. All right. So now we know about antidepressants. And so if I were to test you on this, everybody could name off every antidepressant and be able to tell me what class it comes in, and they'd feel pretty strong about that. No, just kidding. But let's talk about antipsychotics. So the first generation, so antipsychotics, typically broken down into these three subclasses. Now, I will say there's probably a bunch of psychiatrists screaming at the screen right now. What the heck is a tertiary generation antipsychotic? A lot of conflict over whether this exists and whether we should call it tertiary or third. Tertiary sounds, I think, silly next to after first, second, tertiary. But hey, it is what it is, and we'll talk about why that might be a little different. Some people will just consider it a second generation antipsychotic. Some people will just say, okay, first generations are typical antipsychotics. So you might hear that. You might hear neuroleptic, lots of different words. And then second generation or even third generation or tertiary generation would be atypical. Give you a little bit of background just so you're aware. So chlorpromazine was first discovered in 1948 by a French surgeon. He used it to induce relaxation and indifference in surgical patients. It wasn't available in the US until about 1957. It was the first antipsychotic. It is typically thought of as a low potency antipsychotic. There are also mid potency, loxapine specifically, although sometimes we think about that as possibly an SGA, a second generation, and then some high potency like haloperidol, which I'm sure a lot of people have heard about. One thing about first generation antipsychotics is very common to have movement disorders, especially with higher potencies. So, and they can be very sedating, and there can be an increase in prolactin excretion. And so you'll potentially see lactation in folks who are taking this, and there might be a lot of cardiac side effects. Typically FGAs are used to treat the positive symptoms. So the hallucinations, paranoia that you might see with psychosis. Not so good for treating negative symptoms, which are more like apathy, anhedonia, lack of interest, social withdrawal. The easiest way I have to remember that is that positive symptoms are symptoms that are going to be there that shouldn't be, like hallucinations. And negative symptoms are going to be symptoms that should be there but aren't. Okay, so that like that apathy. Couple of examples. I'm going to go through these pretty quick since you're probably not going to see a ton of these. Although if you are seeing a bunch of these, might need to reevaluate, but hey, who am I to suggest that somebody can't be on a medication that's been very helpful for them? Okay, so chlorpromazine, fluphenazine, haloperidol, that's a big one. You'll probably see that a lot, especially on an inpatient, or peridol. Typically not, you don't see it too often, I think, just being prescribed to somebody unless they've been around for a long time. That one came out in 1967. There's loxapine, there's perfenazine. Interesting, perfenazine can be used for nausea, severe nausea and vomiting. There's thioridazine, thiothixine, and trifluperazine, which came out in 1959. Trifluperazine can treat non-psychotic anxiety. I would say I've almost probably never seen that happen. Chlorpromazine, though, however, can, besides treating psychosis, can also manage mania and then nausea and vomiting, or oddly enough, intractable hiccups. So if you have a patient who has intractable hiccups, consider chlorpromazine. I would say if I told you the brand name, you would be like, oh yeah, that's what it is. Next, these are the atypical antipsychotics, at least the second generation. So in 1989, so if you think about, we went from the newest, go back, ish medication in this class, and the first generations came out in like 1975, and so here we are in 1989, and we're seeing clozapine for the first time. And what we discovered is that with the first generation antipsychotics, which are predicated more on just dopamine antagonism, so blocking dopamine, which was causing a lot of extrapyramidal symptoms, so Parkinsonian type symptoms where somebody has a hard time moving. You started seeing the addition of a serotonin receptor antagonism, so blocking those receptors as well. and it seemed to help a lot more with the negative symptoms. So unfortunately, there's a lot more weight gain with this class, a lot more metabolic effects, and so you'll see diabetes much more commonly, a lot of cardiac risk, seizure risks. As far as clozapine goes, we'll talk about that, but a lot of these are actually frequently used to treat bipolar disorders and mania as well. So you'll see that quite a bit. A lot of these have long-acting injections as well, which is nice. So not just having to take a medication every day, but something that can be given as a single, it can be a shot every month or every 2 weeks, or just however it's actually, however it's made up. So clozapine, 1989, is used particularly now for treatment-resistant depression. It's considered probably like the most effective antipsychotic, which is great, except that really difficult to prescribe for a lot of reasons. First of all, you have to titrate, you have to bring up the level really slowly, really slowly. You can't go fast with this one. It requires a lot of follow-up. Okay, so a lot of labs. Really have to get so many labs all the time, because you're looking at their white blood count, you're looking at their complete blood count, make sure they're not having what's called agranulocytosis. So wonderful medication that works really well. Lots of weight gain, lots of sedation, really difficult to manage. But if you're getting to the point using clozapine, you've probably tried a few of these other ones and haven't had much success. So for schizophrenia. There's acenapine, which came out in 2009, had a really bad taste, so they had to change. They had to give a black cherry formulation, I believe, because people were complaining about how bad it tastes, but used for schizophrenia and bipolar mania. I'll name a bunch of these. Risperidone is probably a really big one because it can be used for irritability and autism. It certainly can. It has an FDA approval for that, so just be aware. You're probably seeing that one a lot, risperidone. With risperidone, however, you can see prolactin levels really do go up high. So, and a lot of these can, but risperidone particularly. Paliperidone, which is just a metabolite of risperidone. You have olanzapine. Olanzapine you might see a lot of, especially inpatient as well. Actually, really great medication in combination with fluoxetine, which is an SSRI. It can be used to treat bipolar depression. There's only a few medications that have that FDA indication. So that's a nice one. Actually, really great and antipsychotic. But again, lots of weight gain, lots of sedation. There's quetiapine, which I know people have seen this prescribed. Quetiapine is actually a fairly weak antipsychotic, lots of weight gain. It has indications for schizophrenia, bipolar depression again, so another one that can do that. Can treat mania to some extent. It can be used as a depression adjunct. Really doesn't have an indication for sleep, and so if it's used just for sleep, might want to think that through a little bit. And we'll talk about why that is in the next part of this lecture series. There's iprasidone, iloperidone, lumateperone. So we'll just keep moving on. So here's the tertiaries. So why are these different? Why are these different the second generation, or why are we thinking about them a little bit different? So with, if you remember, we went from the first generations, we had a lot of dopamine involvement and really just blocking, and then we added serotonin in here. Serotonin. You guys are getting like a true college lecture here with this writing. What they added here, what you'll see more is partial agonism. Okay, so what is partial agonism? I deleted my word somehow. Partial agonism is where it doesn't fully stimulate the receptor, but doesn't fully block the receptor either. So it's kind of interesting. You'll see this a lot. You'll almost always see this in these medications. Psychiatry has a lot of medications like this. Usually potential for a lot less weight gain with this, but maybe a lot of, and even metabolic effects, but maybe a higher risk for akathisia. So you'll see people just have this really difficult, like uncomfortableness that they feel like they have to move, and then some extrapyramidal symptoms. So we have to be aware of that. The medications in this class you'll see probably the most are aripiprazole, which is and the reason you'll see that is because it can be used to treat irritability and autism. So there's those two medications. It can also treat Tourette's to some extent, agitation with schizophrenia. It can be a depression adjunct. You'll see it with schizophrenia and bipolar. There are a few newer ones: brexpiprazole, cariprazine, lorazepam, that you'll see. Lorazepam not as new. You might see this one. lurasidone, also used to treat bipolar depression. So we went over the three big ones that are quetiapine, olanzapine with fluoxetine and lurasidone for bipolar depression. There we go. All right, so we have 2 sections down. We have 3 to go. Oh, I'm sorry, there was a question that I missed because it was a long time ago and wasn't applying to me. Okay, so we're gonna go over mood stabilizers and anticonvulsants. So as a psychiatrist, these are the medications that are used to stabilize mood and then maybe reduce the risk of and or treat mania for those who would have bipolar disorder. They may have a lot of off-label uses. Okay, so when we use something off-label, basically FDA is saying that's not an indication for it, but we may have found a lot of data that suggests it might be helpful. The FDA just hasn't looked at it, or they haven't submitted the request to the FDA to make that indication. Whenever we do use things off-label, especially in this demographic, we do want to make sure that we are paying a lot of attention and giving a lot of informed consent to caregivers and patient. Okay, as a neurologist, you might see these medications used a lot for treat seizures, migraines, various neuralgias, but we're going to focus on the psychiatry side. Okay, all these anticonvulsants though are going to have a black box warning for increased suicidal ideation. So the most common side effects in here are going to be dizziness, somnolence, headache, nausea. And then there's like specific ones and monitoring requirements. So I'm sure people have heard of lithium. That's a big one. And then valproic acid. That's an L. Valproic acid. Those are probably 2 big ones that we'll see specifically as mood stabilizers, both used for bipolar disorder to some extent, acute mania. You'll see that quite a bit with lithium and valproic acid. These do have some monitoring requirements that we'll have to think about. There's something called oxcarbazepine, which is not indicated for bipolar disorder by the FDA. It typically treats seizures, but if you have somebody who has seizure disorder and may have some bipolar symptoms, oxcarbazepine might be a great one. There's lamotrigine. The thing about lamotrigine is that you want to make sure that it is being brought up titrated very, very slowly as well. There's usually a starter pack that you get that's going to tell you very specific instructions. If you take these 2 together, they will modify their doses, the amount of medication. So you have to be really slow with lamotrigine. You'll have to double the time that you take to increase it. So just be very, very careful if you're going to do that. And usually it's better not to, but if you're going to do it, that's what you need to watch out for. The problem with bringing lamotrigine up too quickly is that there's a really dangerous deadly rash that comes along with it. We think about SJS or TEN, so Stevens-Johnson syndrome, or toxic, it's escaping me now, apologize. But anyway, so be careful. If you see a rash of lamotrigine, you really should stop, seek out some help, make sure that it's not dangerous. A lot of people actually get rashes, but not all of them are dangerous, but you need to check it out anyway. And then there's carbamazepine, which does have some use in bipolar disorder. There are a bunch of novel anticonvulsants that do have some off-label uses. You'll hear of gabapentin, pregabalin, topiramate. None of they're all off-label, and so gabapentin you might see with anxiety disorders, pregabalin for anxiety disorders, topiramate might be used for obesity, bipolar disorder, PTSD, binge eating disorder, and then there's medications that we just have no psychiatric use, and that's gonna be like phenytoin, levetiracetam. That one we don't care for a whole lot in psychiatry because if we're seeing somebody with that, they're probably having problems, and then ethosuximide. ADHD is very common. Obviously, we need to. It's hard to identify with somebody ID, but if you evaluate carefully, you can find it. Just make sure that when we're using treatment, we're just monitoring really closely. It can be really difficult to distinguish between behaviors, hyperactivity, mania, anxiety, depression, especially if communication is limited. So here are some medications, basically stimulants and non-stimulants. Okay, you're either gonna decide to use a stimulant or non-stimulant. You can combine these to some extent. There's actually a bunch of different classes folded into non-stimulants, but this just simplifies things quite a bit. The stimulants are going to be categorized by methylphenidate or amphetamine. Okay, and it doesn't matter. Methylphenidate or amphetamines. Okay, basically all the stimulants are going to be either one of those. if one isn't working, you can try the other one. The difference is really going to be like, how much does it cost? How new is it? What's the mechanism? How potent is it? And is it going to be long acting or short acting? A lot of the times, the potential for all of these are actually going to be controlled substances, so Schedule 2, really high risk for diversion. Okay, we want to make sure that you're really watching these medications. All of these function off of, in some way, norepinephrine, dopamine reuptake inhibition. Sounds like something we heard about earlier, but there's a lot of potential for psychosis, aggression, worsened tics, Tourette's, seizure, growth inhibition, weight loss, cardiovascular risk, especially for those who have that in their family. So, and which is very common in ID. So we have to make sure we're monitoring cardiac effects. There can be commonly headache, insomnia, abdominal pain, irritability, agitation, more tics, increased heart rate, jitteriness, and anxiety. So sounds good. Sign me up. Commonly, you'll see so methamphetamine is actually was produced in 1943, and it is you can prescribe this. You don't, but you could, and you could prescribe for ADHD. 1943. It is just medical grade. I can't write the 4. There we go. 4 and 3. There's also amphetamine, dextroamphetamine, mixed amphetamine salts, lisdexamphetamine, and then various versions of methylphenidate. Non-stimulants, so various mechanisms. There's a serotonin, norepinephrine reuptake inhibitors, selective norepinephrine reuptake inhibitor, selective alpha 2 adrenergic agonist, selective dopamine reuptake inhibitors, or norepinephrine and dopamine reuptake inhibitors. So we'll talk about just a little bit. The selective norepinephrine reuptake inhibitor, atomoxetine or Strattera, that one's probably a little bit more common. Atomoxetine. Sorry, I did it. So atomoxetine. It can actually be really helpful. Might help with depression as well. So if you're trying to get like that double effect, that one can be really good. You'll see, and bupropion as well, also off-label for ADHD, but really good antidepressant, can help with smoking cessation. So if you're trying to get those multiple effects, you can as well. There's going to be modafinil, which is very off-label for ADHD. You'll see that for people who have issues with staying awake when they have obstructive sleep apnea. There's also guanfacine or clonidine. These are both the selective alpha-2 adrenergic agonists. Basically, they do help with blood pressure, but you can sometimes see hypotension, so you have to watch out for those. Sedatives, hypnotics, and anxiolytics. This is gonna be a really confusing group of medications because there's a lot of overlap, but I'll try to tie them all together if I can for you. So there's benzodiazepines and Z hypnotics, or the Z drugs. Benzodiazepines are typically used for generalized anxiety disorder or even panic disorder. Sometimes use benzos for insomnia, but they're very short. If they're very short acting, Z hypnotics are used for insomnia. I will foot stomp. I probably say this a million times. These are not necessarily the medications you want to prescribe people with ID, as they can be very disinhibiting. There's a lot of, unfortunately, abuse potential. You can become quite addicted to these and have withdrawal. So just be cautious with these. Benzos and Z drugs actually have very different structures, but they both work on the GABA receptor, which is very disinhibiting. Okay, but it's also going to be very sedating. Z hypnotics are going to be a lot more specific to the receptor and have a lot more to do with sleep. Don't typically treat anxiety. Benzos can come in short or long acting, much more higher risk of abuse in the short acting compared to long acting. There is a ceiling effect with the GABA receptor with benzodiazepines, so there's less risk of respiratory depression, but long-term use can definitely result in a deadly withdrawal if they're abruptly stopped, and there's high risk for seizures. So a lot of times we'll see paradoxical reactions when we give these to persons with ID, so better to watch out. And then if they are getting these, watch out for withdrawal, and if you're going to lower them, do it slowly. Typically, the benzodiazepines and with AM or PAM in some way, alprazolam, clonazepam, diazepam, lorazepam, oxazepam, trazodone, temazepam. You hear that, you're going to think benzodiazepine. The Z drugs, Z hypnotics, zolpidem, zaleplon, azopiclone. There is zopiclone, not available in the US. None of these are intended for long-term use, so just really avoid using them nightly and long-term. And then the anxiolytics are going to be medications that are specifically used for some type of anxiety that aren't necessarily benzodiazepines. And so a lot of times they're unfortunately used for off-label use, but they do seem to work. Buspirone is a serotonin partial agonists. So we saw that with a lot of antipsychotics, right? And actually some atypical antidepressants can do this as well. Good for anxiety, should definitely give it a try, but it really only does that. So it's typically used as a adjunctive treatment. Can be difficult because you're prescribing it very frequently, but it's all right. Prazosin, we'll put that into the category. It's an alpha-1 adrenergic antagonist. What all that means is it's also blood pressure medication to some extent, and it is off-label use for PTSD-related nightmares. And so if you have somebody who has a lot of PTSD, which can happen often with ID, we should be mindful of that particular medication, its possible use, especially for sleep, right? And then propranolol is going to be used a lot. It's a beta blocker, so it can slow down the heart or prevent the heart from really speeding up. And there's some central activity in the brain as well, but off-label use for performance anxiety typically. And then last, the sedatives. These medications are used specifically for sleep. Okay, so either on or off label, and they can be divided up into a whole lot of groups, but we're going to focus more on antihistamines, tricyclic antidepressants again, trazodone, hey, and then DORAs, not the Explora, but DORA, dual orexin receptor antagonists. We'll talk about the dual orexin receptor antagonists real quick. There's limborexant, suvorexant, daridorexant, and all of these medications are incredibly expensive. I haven't seen them used a whole lot. It's hard to get insurances to cover them, but the idea is that they decrease the wake drive through OXR1 and OXR2, and they promote wakefulness. And so what they enhance sleep by they block those, so they decrease wake by blocking wake, right? So they increase the sleep by blocking the receptors that are responsible for keeping you awake. Makes sense if I said it properly. There's also histamine receptor antagonists. So doxepin is a TCA, and it actually it works well at very low doses. It has a lot of histamine receptor antagonism. So something that makes you really sleepy, like doxalamine or diphenhydramine. Should probably avoid these though in patients who have ID because there's a lot of paradoxical reactions. There's a medication called Ramelteon that is a melatonin receptor agonist. It is approved for treatment of insomnia in the US and Japan, but not in Europe. It is particularly useful for people who have a hard time with onset of sleep, but not necessarily sleep maintenance. And so Ramelteon works on melatonin. So when you see people taking melatonin, that's what this is. Trazodone is another one that we talked about earlier. One of the reasons we don't use it for antidepressant or for depression, typically trazodone, is that it's just so sedating. But it works pretty well for sleep. So let's keep on. All right, so there we go. I got through all that as fast as I could. Apologize if I went too fast. You all feel like you are experts now in the psychopharmacological management for ID. Gosh, I hope not. But if you are, maybe you can give this lecture to me. At this point, though, hopefully you are able to recognize some of the common medications in the classes, okay? I want you to be able to, if you can, you see a medication or at least have an idea, this is what the class does. This is why we're using it to treat. Be informed. All right. Any questions? We have a few minutes. Again, I apologize. Really going through that quickly. If stay tuned at some point for the second part of this lecture, which is going to go into how we're going to use these medications, some of the tips and tricks on how to use them, or at the very end, and some of the monitoring that was going to be required or at least recommended for patients who have ID. And thank you, Serena Jordan. I appreciate that. Any questions at all? I'm opening up the floor. I did put a very stripped down version of these as handouts if you want. I didn't throw my notes in. Hopefully you were able to take notes, but at the very least it might be. When is part 2? That's a great question. It has yet to be scheduled. I don't know if it's going to be a live webinar yet or if it's going to be a video on demand. It will be one of those, but it will be me and it will be like this. Oh, do we have? I thought I maybe heard something. Anything else? Oh, here we go. Oh no, what happened? Okay. Which medications, sorry, I'm looking, do not respond when a patient has FASD? I don't know off the top of my head. I can look that up. Who is the asker here? Sorry. Um, my screen is not helping me a whole lot here. Holly Jones. Um, I, that's probably like a really super specific question. I would say I will try to get back to you as soon as possible. There are some interesting medications that I'll go over on the next one, so that Fragile X actually has a lot of really interesting off-label use medications, which I have found to be somewhat helpful in other patients as well. And to be quite honest, a lot of the things I've learned when treating other people actually came about while treating ID population, because you do have to be really specific and really slow. So I apologize for not being able to answer that one.
Hey, Dr. Dixon. We also have another question above that from Megan Bamba. Is pharmacological restraint a big concern? And if so, what meds are more commonly seen?
Oh, that's a great. Yeah, pharmacological restraint is a huge concern that I have. Absolutely. And a big reason why I wanted to highlight a lot of these different things. And a big reason why I want you to ask about the indications. Why are we using this medication? Atypical antipsychotics and typical antipsychotics, the FGAs, the SGAs, the TGAs, those are often used for chemical restraint because they are so sedating. You will also see you'll see mood stabilizers used extensively, the anticonvulsants. To some extent, I would say the benzodiazepines, because they have that paradoxical reaction, you might see them tried, but they tend not to be particularly useful, but you'll definitely see that used. I do have a huge issue when that is done, because I do think that's pretty inappropriate to just try to chemically restrain somebody, when ideally we should be treating their underlying symptoms and hopefully managing behaviors in appropriate ways, and really help. Uh, I wouldn't, the big question is, would you do this to your kid? And if the answer is no, then maybe find a solution otherwise. I don't know if that's helpful, but you'll commonly see that with sedating medications in particular.
Okay, we've had a couple more questions pop in
Sure.
from Jennifer Kaufman. Is there a good medication for anxiety and ADHD?
For anxiety, ADHD, that's a good one. That's a normally, so one of the ways that we kind of classically think about that would be, if we treat the ADHD, does the anxiety get better on its own? Very possibly. One of the medications, so bupropion is one that has that off-label use for ADHD, can treat depression. Isn't always great for anxiety. However, anecdotally, I have definitely seen where that has helped folks who have both. It can help that anxiety. The other thing you may just have to think is, okay, well, am I going to use something that is a non-stimulant for the ADHD, and am I going to consider using, what are the risks and benefits of using an antidepressant or another anxiolytic in particular to treat the anxiety? So can I get an effect? Um, Anything? And then there was another question. I just can't see them for some reason.
I've got it. From Isabel Espinoza, what medication is more recommended for negative symptoms?
There isn't a particular medication that's going to be more that is going to be more recommended, but when we're talking about the negative symptoms of like schizophrenia or psychosis, the second generation or third generation antipsychotics are going to be much more effective, if not than treating with a first generation antipsychotic classically. So not any particular one. What we usually do is look, what are the individual side effects that you can see? What are the co-occurring, symptoms that we might need to treat, and kind of tailor our treatment to that. But typically, very broad way, second generation antipsychotics, third generation, or just atypicals. Anything else?
I think that is all the questions currently in the Ask box.
Okay. Well, and there we are. Luckily, we just hit our hour. So I appreciate everybody who asked questions and for taking that time. I hope I made some sense. I believe this will be recorded. So if you do have to go back to figure out what the heck I was saying, please feel free. But we were sponsored by OMHAS. So yay. And those are my references. And thank you so much. Have a wonderful, wonderful day.